thinker, an unreflective thinker, right? So you can be any of these. And what is important to understand is when you put somebody in a box, say this person is a challenge thinker, this person is an advanced thinker, always understand that the level will change depending on the situation and depending on, you know, that particular situation. Say sepsis, all of us, you know, it is like Kotina Pindi, we all know. But suppose there's a case with SJS, or there is a 10 that is coming after 6 months or after a year to your ICU. Then again, you have to become a challenge thinker. Most of the situations, you are a challenge thinker, unless you're somebody with very profound memory and you remember every single fact about every single disease. So remember that this is dynamic. Slide maratledu. Okay. So next we looked at tips for educator. All these are like what we regularly do. So these are from these practical tips. It's all from last class, sir. Setting goals for rotation, creating a safe environment, setting rotation expectations, what you expect in the round from the resident, diagnosing your trainee, what level your trainee is. So you can't ask them to talk about ARDS trials if they don't know what is ARDS, right? Then be prepared for rounds before you go there, not there impromptu. Let the trainee talk, get a commitment, involve the patient. That has to be the center, right? Admit personal knowledge gaps, using teaching scripts, pre-prepared small pieces of knowledge that is very useful. Use them. Using hypothetical situations. What if this patient was in shock? What if this patient presented with this rhythm in this situation? What would you do? So that you broaden, and providing feedback. So what is this 1 minute preceptor? Again, you have a prepared sort of set of small knowledge pieces which are on one particular topic. Say it can be augmented renal clearance, or it could be drug distribution, or it could be vancomycin. Say something like that. Small bits of information where in 1 minute you should be able to give the learner good amount of information. That is a 1 minute preceptor. Then mini chalk talks, again, these can happen. You can use, you're talking about something and then you can just, if there are 2-3 people, then you can just draw paper. Say you're talking about a lung mechanics, or you are talking about, so you can use those kind of techniques. That's a mini chalk talk. So then again, very important, it needs effort on the part of the facilitator or the trainer. Prior to round, you have to prepare, you have to plan, and you have to orient yourself. Then you have to introduce the team to the patient, especially if the patient is, you know, overnight admission, new admission. Then treat patient, establish that interaction, observe what the learner and how the learner is interacting, instruct. So like there will be one finding, you know, in one particular case, say, especially when these cases are rare, like, you know, you take those opportunities to tell about that particular point and teach them, engage them for 1 to 2 minutes in active teaching. Then you summarize whatever has happened there. So when you come back and sit for chai, you can sit and summarize, and chai breaks can be very useful. Then following rounds, debrief, feedback, reflection, and preparation. This can happen either on chai or it can happen anywhere else. So another way of looking at is the care format. C is for climate, create a climate, give attention, plan the encounter in advance. Say you know that, you know, the facilitator would obviously know that this particular patient is admitted last night, right? Most of the times they know it. So, no? Sharing undi kada ikkada? Up down chest. Stop share. చేయాలి. వదిలేస్తున్నాను.
అదే సెలెక్ట్ చేస్తాను మేడం.
అది కాదు మెయిన్ పీపీటీ అది లేదు బాబు, దీన్ని మినిమైజ్ చేయటం, దీన్ని మినిమైజ్ చేయదు ఇదా. ఓకే, మీ పీపీటీ ఏది వరలక్ష్మి? అది కాదు, దీన్ని అసలు స్క్రీన్ మినిమైజ్ చేయి. అది మీ పీపీటీ ఏది? ఇదా పీపీటీ ఇది. అలా కాదమ్మా, ఇప్పుడు ఏది అది కాదు, మళ్ళీ స్క్రీన్ ఓపెన్ చేయాలి. అది ఓపెన్ చేయాలి. ఏది ఇది కదా. స్క్రీన్లో పెట్టాలి. ఇప్పుడు అదేది ఇది కదా. ఇదా ఇప్పుడు దీనికి ఇది కదా. ఇది పక్కన అయిపోయింది, వచ్చింది కదా. ఇప్పుడు వస్తుందా చూడండి సార్. వస్తుంది.
ఓకే సార్.
అక్కడే పెట్టాం ఫుల్ స్క్రీన్. ఫుల్ స్క్రీన్ పెట్టాం కదా ముందు.
స్క్రీన్ పెట్టి అప్పుడు స్క్రీన్ షేరా సార్? స్టాప్ షేర్ చేయండి.
ఏంటి తీసేయాలి? ఏంటిది ఇది క్లోజ్ చేయాలి.
ఫుల్ స్క్రీన్
చేసి
దాంట్లో పెట్టాక చేశారు, అది చేయలేదు.
ఇదే ఎస్కేప్ పట్టగానే వెనక్కి వెళ్ళిపోతుంది.
స్క్రీన్ కొడితే పోతుంది కదా మనం.
ఇది కదా. తెలీదా? ఫుల్ వచ్చింది కదా. ఇప్పుడు చేంజ్ అవుతుందా? ఇదే ఓకే. లక్ష్మి
So we were here, right?
Yeah.
Climate, attention, reasoning, and evaluation. Avoid read my mind questions. So what do you see? It's very common, I feel. Teachers have that tendency. They have something in there, say a graphic or something. They say, so what do you see? The learner is not able to understand. So you have to just move on, right? Say, so now look at the graphic. Look at the inspiration. Look at the pressure time scalar. What do you see there?
That is why the practical exam is biased, no? Because practical exam, the examiner mind is different, but what we read is the student is different.
Exactly. That's why if you keep on repeating, somebody was telling me the other day that what we did during the exam prep was Ryle's tube feeding. Somebody commented, but that's aside. I don't think that's Ryle's tube feeding. That is intelligent teaching. So climate, attention, reasoning, and evaluation. Okay. So whenever you evaluate, avoid pointed criticism. Don't say inta kuda telida. What, you don't know this. That's a wrong way of doing it. We tolerated it as sort of not tolerated it. We were okay with it as learners, but future learners are not that way. They're built differently. They're because that is how life progresses.
AI, no?
Yeah, they are with AI.
AI.
And so it depends on how you use the AI, right? AI can be good, it can be bad. So let's hope it is good and they are better than us. So then we looked at the flipped classroom concept, where everything is given before all the information. There is a video that is given, for example, a video that is given, and then during the class, during the sort of interaction, it's more just interaction. You have a case-based discussion. It's not like you're diagnosing, this is the etiology, these are the clinical features, this is a differential diagnosis. You don't go that way. All that is there prior. You start with a case history and then you say, so what will you do? So you have some images, you have some that kind of a teaching. Then we looked at individual separate scenarios where teaching is lacking or facilitation is lacking and it has to happen. One is handover. So this is one of the key skills, right? It's one of the key times in our ICU. So it's important that during the initial few days, especially for new residents, that a senior person hands over and the learner actually sees, understands how things are done and can follow, so that there are no major mishaps. Then how to learn procedures, how to teach or facilitate procedures. First, of course, theory, then observation, then pre-procedure, maybe a video review, then supervision, simulation, and feedback. I think we stopped at this last time, right? If you remember, we had gone to simulation. Simulation, we all understand it is a very useful tool. Why? Because no patient is at risk, no life is endangered. That's the reason simulation is good. And the hero in simulation is, I think we stopped at this last time. The hero in simulation is, any answers? Sorry, sir.
Satish friend is there.
Oh, that's good. Yeah, that's what I was talking about last time. So who is the hero in simulation or the heroine? Any guesses? Who is the hero or heroine of simulation? Yeah, Superman, Superwoman. Yeah. Superman. Okay, let's assume. Who's the hero of simulation? Huh? Mannequin. Any other answers? Volunteers. Volunteers under kada. It's assumed that it doesn't need volunteers, but if volunteers are there, maybe. Inka?
Operator.
Feedback. Debriefing. Debriefing is the hero, not anything else. Right? You have to know, you have to be able to. So who gives feedback? That banda is the most important banda in simulation. So you have to take whatever AI, whatever simulation, finally it has to go back to one person thinking and talking about it. That is important.
Entire something, entire India, the best simulation is in Rajasthan.
Huh, yes. Yes, they have a setup. Do they have a good debriefer? I don't.
We had
So next, coming to this use of technology, going further on it, please let me know 5 minutes before the time, so I'll finish it. Leveraging telemedicine. So what these people did in this study is, they had video recording of all the codes that were happening in the ICU and in the ER. All cardiac arrests, all resuscitations were recorded. Then they selected a lot of those recordings and then they studied them. And depending on that, they gave a feedback. So, and this was, if you can see, now this is in the University of Pennsylvania, I think. If I'm wrong, I forgot. Pennsylvania. So there is a code happening, so it gets recorded. And they have the biggest, most sophisticated tele-ICU setup in the world, it seems. So, and it is run by, who's this lady there? They are generally nurses, critical care nurses. They run the show, the telemedicine. So they will record all these, and then those records are sort of, were all sort of analyzed, and then feedback was given, right? So they used this study, and it was a very useful tool. They were able to reduce the number of adverse effects. So maybe we can consider using one of this. Then artificial intelligence, that is the buzzword. Everybody talks about AI. It is being used even in critical care units. It is being used increasingly, from starting from mortality risk stratification, then prediction of non-fatal events, to phenotyping, to echo interpretation, to ECG interpretation. All this they're already using it. So why I put this slide? Yeah. Machine learning in the modern critical intensive care unit. So these are all studies which have reported use of AI for all these functions. So they have categorized the tasks into these categories: mortality risk, stratification, prediction of non-fatal events, phenotyping, echo interpretation, and ECG, because it's a cardiac ICU. So this is just to give you a spectrum. So why I put this slide in our scenario is, so there are a lot of free learning options and platforms now that are available for us to learn and understand artificial intelligence. I know Manjula ma'am was listening to a webinar on the same a few Sundays ago. And unless we go and we sort of latch on to it and we start learning and understanding it, we will go to a situation like that, where in a few years, we have to start learning things from the scratch, because they'll never be the same again. Textbooks and the formal way of teaching, I think, will cease to exist in a few years. Unless we latch on, we'll have to become like this, sort of village folk who are starting with adult education when they are 50 or 60 years old, and they start writing IE. It'll get to that stage. So it's important for us to learn and understand AI. Crisis resource management, again, few key points: situational awareness. What is the skill required? Situational awareness, problem identification, workload distribution, and decision making. Even this has to be taught very objectively to the learner. It has to be inculcated. What will you do in a crisis situation? What will you do in a crash? So during the crash, not shouting, bring that, bring this, what is this? Don't say things like that. Practice drill for a crisis resource situation. Situational awareness, problem identification, workload distribution, and decision making. So what's new? Upskilling and reskilling, like I was telling you. For us, it would be maybe learning a new procedure, learning a new technique of doing a new procedure. Say, for example, something as simple as an ultrasound. Using ultrasound, you are learning 2D echo, then maybe interpreting an EEG in the ICU, a bedside EEG, or it could be AI. So you should know what algorithm is sitting, or a new mode of ventilation. Those will be the kind of things. And reskilling. You think that you attend one conference, one workshop, and you know it. Generally, it doesn't work that way. We have to keep on practicing it and become micro learning. This is very important. Not big topic. Like, don't keep AKI as your topic. A small component of AKI, like I was discussing with the Akshat the other day. Small components, say AKI recovery, say AKI risk factors, AKI sort of definitions. So if you break them into small sort of bits and pieces, maybe learning is more efficient, more useful. Personalized learning. Learn the way it works for you, how it works for you, and how it works for your team. Gamification. We have to start using it. A lot of platforms are there, like the ventilator simulator that I was discussing last week. That does involve a lot of gamification. So we can collaborative learning, So you say, it's like, you know, how we used to make, I don't know if you understand the concept of potluck. So each one person brings one sort of item and then you have dinner, all friends together. So something like that.
We only come and eat.
I think that's a old fashioned way of looking at it on any given day. So it is like a collaborative thinking. You learn one, you learn, like, you know, I know something, you know something, and then all of us together we sit and discuss, and then we learn so many things together. I know one fact, but I'm sitting in a class like that, I learn 20 by the time I go home. Exactly. So something like that. Then virtual and augmented reality, if we have it in critical care, that's like the best thing that can ever happen, I feel. If you can create an AR, or if you can create a system where you can teach and simulate critical care, it's still not there. It's not there in the level that it should be there. Data analytics, of course. Any guesses on this? If a resident gets this, they get a prize. Why have I put this? And these slides I put yesterday only in the group, if any one of bothered to have a look. Why this slide? Sorry? Outcome? No. Sorry. Let me tell you, it's a video game. Endeavor is a video game.
Escaping through the wall of the.
No. Any answers, sir, in the chat? No? Any answers on the chat? No. So it's actually the first FDA approved video game to treat FDA approved video game to treat attention ADHD in children. So it's the first FDA approved video game. So we are going there, probably there, you know, like we curse video games right now. If my daughter was playing Endeavor, I would have given a, you know, tight slap on her face right now. But then, I don't know, maybe in the future, this will be the way we all learn. ADHD. So it is time for us to retool the way we learn critical care, right? So what else? Like they say, money may not be the root of all evil, but it's a very good fertilizer. So finally, it comes to that. It is the reason why there is a lot of problem. So how should we go about this? So one is, of course, care must be better selected and tailored. Intervention timing is key. We have to make our learners understand this. So fluid bolus, not whenever there is a hypotension. There are particular situations during an episode of, there are certain prerequisites that have to be met. I'm giving a very oversimplistic example. Then the stage and severity will determine the intervention's value and toxicity. Okay, when you apply what kind of PEEP, when you prone what kind of prone, when you give a neuromuscular blocker, what neuromuscular blocker you give, for example. So why are we talking about this? One, there is a lot of new technology. So we need to learn a lot of new things. That is the number one problem. Second thing is society has changed. It doesn't value, or it doesn't look at physicians the way it used to look, say, a 50 or a 40 years ago. And this societal change has led to the change in the way our health care system works. So vitamin M is very important. M being money. So hospitals are business models. They just want to make money. So they look at us as a tool to make money. They look at us as a mutual fund. Is it going up or down? Is it working? Is it building enough funds for us or no? Should I take it off? Should I withdraw my money from it? Fire the guy. It's as simple as that. You know, they look at it in that way. So we have to adjust ourselves to the scenario. Unless you have the money to open one hospital yourself. I think even if you do that, you will become that person again. So that's how the system works. So even our public people-to-people relationships have changed because learning is no longer, teaching is no longer teaching. Sir corrected me last week. If you're not a teacher, You don't take ownership of the student. If you're only a facilitator, you're like the person in the movie theater who's scanning your tickets. Why will he take responsibility for the facilities in the movie theater? Unless you feel that I am the one responsible for the student, you will not take that kind of an ownership. So I think that is wrong. That concept, if it exists, is wrong. So that is the reason change is. Sorry. Yeah, please.
See, the word they change the teacher meaning is there's something called CBME. Competitive, now the MBBS program, everything is being converted to the CBME set.
Yeah, those slides are there so later.
So in that, the word changes from teacher to facilitator, but facilitator is responsible for too much. They have to motivate the students, they have to include the students, they have to make them understand is the responsibility of facilitator. Teacher means the make it feeling that only the process of that falling they want to remove, and not that the response, nothing is taken, it's actually giving more.
Okay, so few key things that we have to establish as facilitators, or when we teach something, when we do something. One, this is pertaining to critical care. Attempt to re-establish physiological normality is gone. Those days are gone. Where you want a normal BP, normal heart rate, normal lactate, normal, everything, normal sugar. No. It is now critical care is all about adapting the patient to a protracted climb back towards functionality. Somehow you slowly want to bring the patient back to a stage where he or she can sustain and lead a meaningful life. What will adopting normal targets do, especially when you direct treatment for patients with limited reserve? So you will put patients at unnecessary risk, and patients will die irrespective of what you do. So what is the amount of intensity of therapy that you want to apply in a particular case has to be thought about again and again and again. Last evening, David sir and me, we were resuscitating a near 80-90% burns patient. She's a 75-year-old female. She came gasping. She had a cardiac arrest in So you are creating a large cohort of patients with chronic critical illness. What are you going to this? As a society, are we capable of handling something like that? I think these are discussions that we should have on a smaller level. I'm sure they happen on the big when all the sort of presidents and secretaries of the they sit and talk in big conference. It has to happen at a micro level, at a level where we can be part of that decision making. So retooling requires a combination of something old and something new. The empathetic connection that was there in old time sort of consultants and the new technologies of today. We have to build a combination of these two in our future critical care physicians. So they did the study, characteristics of the contemporary intensivist. It was a qualitative study, and actually my questionnaire was sort of an offshoot of this study that I went through. So I thought maybe we can do something like that in our scenario. What they simply did is 19 intensivists, Australia and US, I think, or Israel. Yeah, Australia and some other country. So what they did is they sat somebody who's not related, who's not an intensivist. They interviewed one intensivist for about 2 to 3 hours. They asked him a lot of questions. So they recorded all these, the answers, the conversation was recorded. That's how qualitative research goes, right? So they recorded all this and then they decodified all the information that was there in that. So finally, it came down to around 700 pages of content. So depending on this, they categorized people or intensivists into certain personality types. Okay. So the first category is the fixer. Okay. None of this is this is just research. I've just put it in the form of figures. Who is a fixer? A fixer is a team player who is confident, pays attention to detail, high pressure, functions in high pressure situations, celebrates success, a multitasker, gets instant gratification, decision maker, technologically competent, and a team player. What's the name of this group? The golden retriever, right? So these are the retrievers, right? So what you know what the retriever was used for? It's a gun dog. Somebody shot a dog, a rabbit or a bird. This dog will go and fetch it. So it's the retriever. That means something is, you think this patient is dead and gone. That patient will that doctor will do something and get the patient out of it. That kind of an intensivist. Adrenaline junkies, able to handle stress. They provide a safety net. They think that we are the safety net. It is my duty to save Rosk is my duty. So those kind of things. Very flexible, very skeptical and curious. This group, the diplomat. Okay. High on emotional intelligence, high on compassion, very grounded, consultative, and has a sense of humor. So that is negotiator, good communicator, good interpersonal navigator, tension diffuser. Pragmatist, very practical, honest and realist, diligent, emotional, has good emotional capacity, very resilient, detached, poor memory for bad events, remembers only the good things, tries to forget them. Huh? So these are all groups. Huh? So these are all groups into which they placed intensives. What is this? What group is this? Anything that you can think of? Duck. Consistency. They call them ducks. Why? Because upar se acha, usually the duck is, like smooth sailing. Niche, it's like, sort of. So there's a lot of things happening inside. They internalize a lot of things. On the exterior, they may appear very calm, but they do appear calm and they do work calmly. They're very consistent, but they are very introverted and introspective. So it's like, so which group you think is most prone to burnout? The duck, right? So everybody is, but the duck is. So they created, so they also looked at how they asked questions. What do you think other people perceive you as? The question that was there in the group. I found it very interesting. So there were 3 categories of answers, which almost matched with the 2-3 responses that I got. One is they think of you as a superhero. Okay. So who are these people who think of you as a superhero? You will have saved their patient that day. Some patient that has crashed in the OT or in the ER, Valla Chuttalo, somebody, you would have saved them. For that moment, you are a superhero. They perceive you as a superhero. Second, they perceive you as a dictator. So these are like, this fellow doesn't listen to me. I hope he goes out of this hospital. You don't want them around, even though they are good. You don't want them around. Or you think of them as Dr. No. This fellow will not say yes to anything that I say. It's like what my husband thinks of me, but I don't know how the things work with you. So we have to remember that. See, as an intensivist, we think Yeah, this. Right? But it's actually the external perception that matters. Why did they do this study? Why to put these intensivists in these categories? Any guesses? Why such a study is required? Is it to make fun or is it to make a good class out of it? To introspect yourself? Okay, agreed, sir. Anything else?
Change yourself of introspection.
Okay. To
And God.
to have a broader vision. Anything else?
There's so many people at this.
Maybe.
It's like we have to work as a team or.
Exactly. But why these categories? So their final aim of the people who studied is, can we create a tool at critical care education entry level to say that you need all these to be an intensivist? Now you decide whether you want to be an intensivist or you can't get in and say, oh my God, this is not what I expected things to be. So one of the goals is that to maybe can we use that? That is one of their future goals. I'm sorry about this. I just made a note, but I didn't have the time to make slides. So there's very interesting blog. Why should you not be in critical care? Okay. So it's a long journey, cost, all this, right? So the actual job, again, it depends on whether you're working in a closed ICU, open ICU. The margins of error are small. There is a lot of liability. There is confusion sometimes regarding what you actually do, right? Sometimes there are days when I feel after all these years at 46, I'm a bloody duty doctor, which I could have been when I was 24, and I led a peaceful, nice life, have another child, spent a lot of holidays and done a lot of things. That sort of a thought process is there.
Burnout.
Becoming used to, sorry?
Early burnout.
Becoming used to chaos, interdisciplinary, interpersonal practice. So you need to interact with a lot of people. That's not very comfortable sometimes. Nurses who eat their young, that in front of your eyes, somebody is harming somebody. That, they are doing things that can kill. They are doing things. And you have to just say, hello, ma ila cheseva. It's okay. Isari ala cheyi. If you shout, then I start because I was nurses who eat their young. Elagaithe paamulu valani pillalu valani tinestayo, nurses eat up. There are nurses, I mean, no nurses in this class. There are nurses who are very smart, who may be better than the doctor. If it is a new duty doctor, the old nurse is 100 times better than the duty doctor. But there are also nurses who are as vicious as that. And we have to deal with those. And it takes a toll on you because you cannot do anything. You cannot let them go. You cannot do anything. Right?
That's when you don't shout at that particular nurse, you shout at the in charge of that area. They
Correct.
should know the capability of that nurse and not the patient.
Correct. So what if that person is a python? What if the in charge is a python? Anyway, that's another story. So another problem is you deal with the death, which is like an elephant in the room. This patient is going to die, but the family knows that the patient is going to die, but still you have to say, sir, I think your patient is not going to make it. And then they are like, oh, is it? He was doing okay. Exactly. So it is like, something that is there, it is there, and still you have to sort of do all this dramabazi sometimes. Then the feedback loop within your team, if it is bad, then you don't want to cause harm. And people, I think, have stopped dying at home anymore. Everybody, 90, 92, 94-year-olds, everybody are coming to the ICU and they want everything to be done. Don't know what their expectation out of life is. Then you have to deal with sudden deaths. Then young people dying, that can be very stressful for for everybody in the ICU. Then there are two complexes. One is the God complex. which is part of this blog, and the other is AI complex, which is David Sir's contribution to this slide. The God complex is where some physicians think they are gods. They think they know everything and that they are gods. Dealing with those kind of physicians is very challenging. AI complex, again, some physicians think that they have a big AI tool in their brain. So they put information and they get an output. Okay. And it's assumed that you have to believe that output without any questions, any doubts, right? So that is the AI complex. Those things make working in an ICU much more challenging than these. I think long journey, fellowship, scheduled logistics, long shifts, no lunch breaks, no holidays. We can still deal with it, at least till a particular stage in your life. But the other things are. So coming to what Sir was talking about, competency-based approach. We know that that is what is being inculcated in undergraduate medicine. It has started off in MBBS. So how should we incorporate it in critical care? Of course, you know, the Cobatrus, I don't know whether it is required now. We used to fill the Cobatrus format. The Cobatrus format for IDCCM exams. Does it exist now? We used to fill that Cobatrus format for the exam. We used the requisites, like, you know, these are all patient, this doctor is competent in, so you have to write all the things that you are competent in, and your trainer has to certify it. So there has to be a minimum number that, so that you can take the exam. I don't know if it is in place now. So in addition to that, that is very difficult to employ and assess in critical care, right? So I can say, do you know CPR? I know CPR because CPR, ACLS, it has a way of assessment. But if you say, what do you know intercostal drainage? Then what does that mean? Even if I know ICD means intercostal drainage, it means I know intercostal drainage. Do you know, does it mean that I know how to put an ICD? Does it mean how I can set up an ICD? Does it mean how I can use a multi-chamber suction system or a multi-chamber drain? I think that was there in your teaching plan the other day. I was going through it, right? So how do we incorporate all this? So there is something called entrustable professional activities. So for every procedure, everything that we do in the ICU, you have to have first a teaching module. Okay, teach them everything, teach them the theory, teach them the practice, teach them the complications, so on, whatever is required for that particular. Then you take them to a simulator. Then you make them do the procedure under supervision, see the number of complications, have a number, say for ICD 5, for intubation 20, something like that. I'm just giving examples. Then you let them do the procedure by themselves. Initially by remote supervision, thereafter by themselves. Then you have a list like this: mechanical ventilator setting in acute respiratory failure, executing patient handover, ACS management, family conference. So what are these MKPC? It's there here. See, it is what is the medical knowledge, patient care, interpersonal skill, professionalism, practice-based learning and improvement, systems-based practice. So all these have to be incorporated when you assess this patient, this learner with a particular skill. Okay. So is it useful? Yes, this study has shown that this kind of an approach is feasible and useful. So maybe we can copy it. Last slide. Coming to ICU resilience. We talk about human resilience and critical care physician resilience, right? You have to say critical care is not for the meek-hearted. You have to be very resilient. What about your ICU? So this is a recent article. So they look at how you can measure. The head will always, my ICU is the best. It is the most resilient ICU. Because he or she will get to go home at 5 o'clock and have a chai or coffee with their family, and then get a call on which he or she can shout on the resident and say, ye bhi nahi kiya, wo bhi nahi kiya. Next day morning, come on round, find all the faults, right? That is what most of the situation a ICU had. So his perception of ICU resilience, his or her perception is incomplete. It is wrong. So what you need is a framework. You need a framework which includes learning, anticipating, monitoring, and responding. How an ICU is doing all these things. So they have found out a metric, a measure, and they've done this during COVID and non-COVID. What they found is, you can look here. This is high resilience ICUs. Wherever they found high resilience ICUs, and this is like what happened during COVID. So this is like low resilience. What do you mean by resilience? That means if there are 10 daily you're treating 10 patients, on that particular day you have 15 patients. Or daily your general case mix is say sepsis AKI. Suddenly you get a burns. Suddenly, one off you get a sort of a different case. How do you deal with that? Suppose there are during holiday season, during festival season, how do you cover those kind of things? Okay. That is, so we have to build a framework to measure and learn. So finally, the same case that we started with last week. Look at this. You are the T is for teacher. She asks, what is your assessment? Resident says 45-year-old male, history of hypertension and ER with sepsis. What is the source of infection? How do you account for? Maybe pneumonia will appear on the X-ray. Cannot find anything, but the resident will say, sir, pneumonia, maybe it's not visible now, maybe we'll see it tomorrow, but it is sepsis only. Okay. Why? Because he came with infection, he has low BP, he has fever, it has to be sepsis, right? So then you take it from there. So finally, you both get frustrated, and then the resident says, maybe, sir, I'm not really sure. It doesn't make sense, but maybe I'm wrong. So this is how it goes. On the other hand, if your question is, what's with this new admission? What are you thinking? I'm concerned there is sepsis, but there are a few pieces that don't fit. However, I couldn't really see the patient properly overnight. I have to see. So the facilitator says, okay, so shall we look at the case together? Or you do something else, I'll help you out with the other cases, and maybe you can have a detailed look at this case. So you will have happy residents and you will have a happy working environment if you look at it this way. Thank you.
I'm ready.
Open for any questions.
See, you stop it. No.
Oh.
So you can stop sharing, not a problem.
Yeah.
Continue the. You can see here, I think everybody is anesthesiologist. Except you. I wanted your perspective. Basically, I mean, it's not that it's from clinical perspective. So what is the difference? Because every one of us, I think one person trained from one area. Myself and David has been trained in Apollo, and Mondra has trained in CNC, and Madam in UK, and he has trained in Kolkata, Raipur, Banjara Care. Yes, now new teacher. New teacher. So, yeah, so he has been from Pune. So with this perspective, I just said, rightly it's like a gist of it, what we are actually. So how do you think that we can improve? Because I look at it as a frame of review. In which area, like I said, we are type of people where we know we can understand ourselves better, we not express outside. But as I said, outside people perception is more important
Yes.
than what you think about
Correct.
yourself. Because always we think that I am right. That's the main problem. Anybody, I face the same problem. I feel that I am doing best. I feel that I am great, or I feel that I am doing my best.
Correct.
But that's not what it is. What is other people are thinking about me is more important.
Sir, yeah, I think
That's the reason
excellent
I
class.
think I'm able to.
So, am I audible? Hello? Am I audible? Hello?
Yes, sir. Srinivas sir, you're audible.
Yeah. So actually, it's an excellent class. A lot of insights, and after a lot of experience in critical care, first we need to look into the what we got trained and what we are doing. I compare. See, first we need to think that the branch critical care medicine is a super specialty branch. Is it audible, madam?
Yes, sir. I'm not sure I'm able to hear it. I hope everybody is. Give me a minute, sir. They're connecting the.
Yeah.
Better.
చెప్పు.
Hello. Yeah. My.
అక్కడ ఆఫీస్
Officer.
My actually is an excellent class and a lot of insights we have seen. But my perspective after so much of experience, I feel the critical care.
అందరూ చెప్పాలి నో ఇంక్లూడింగ్ స్టూడెంట్స్ ఫుడ్ తెచ్చేస్తుంది పెట్టండి
It's okay, madam. I'll just update you.
Sir, Srinivas sir.
Yes. I'll update you, madam. You can just tell them. Okay, madam. Hello.
చెప్పు సీను
Sir,
Srinivas
this
sir.
after. Yes, sir. Am I audible?
ఎస్ యు ఆర్ ఆడిబుల్
Yes. So, see, the critical care medicine is considered as a super specialty branch. I'll give an example. We are almost compared with like a cardiologist, nephrologist, neurologist.
Srinivas sir, ఒక్క నిమిషం ఆగండి sir. Srinivas sir,
Yes, sir.
ఒక్క నిమిషం ఆగండి sir. They're just connecting the speaker. Please wait for 1 minute.
Okay, fine.
Sir, ఒకసారి మాట్లాడండి sir.
Yeah. No audible. Am I audible now?
You're audible.
Madam, మీరు update చేయండి. Madam. సరిపోతుంది. మీరు update చేయండి.
Sir, hello అనండి.
Hello. వినపడుతుందా?
సీను
యా హలో సార్ మీకు వినపడుతుందా?
ఒక్క నిమిషం సార్.
ఒకసారి లైన్ లో ఉండండి. రామనాయుడు
హలో హలో
ఒపీనియన్ ఏంటంటే లోపలికి రండి. So all this different types of intensivists and different types of ICUs in various parts of the world. Going into the very advanced in progression. Mainly the in charge of ICU must.
హలో వినపడుతుందా? హలో
శ్రీనివాస్ చెప్పు సీను
సార్ వినపడుతుందా?
వినపడుతుంది చెప్పు
Sir, after so much of experience, I feel the critical care medicine training has to be there for 3 years. One, as we are the 1 year or 2 year courses have to be removed. Okay, so I'm sorry. 1 year and 2 year courses has to be removed. And most of the, almost like maybe 80% of the people I feel is from the anesthesia background. So this is a super specialty. So we need to know the total about. Hello, Vinapatna, sir? So we need to know the basic concepts of medicine also. Like it's not only a deranged physiology, how to manage these patients in every diseases and the basic concept of, so that at least we can follow these patients. Because ఇప్పుడు cardiologist and nephrologist and they follow their patients. మనం follow అవ్వట్లేదు ఎందుకు అని అంటే because of these all these things. I think we need to undergo basic for a 6 months. Then we have to enter into the critical care training. I think ఈ 1 year, 2 years తో పని చేయదు. The quality of critical care and the respect to critical care specialists will go down. So these are my insights. This is my thinking, sir.
Okay, thank
Sir.
you, sir.
Thank you, sir.
అన్నాడు ఇంకా చెప్పలేదు. మౌనంగా లైన్ లో ఉన్నాడా, క్లాస్ లో ఉన్నాడా?
సార్ ఉన్నా
చెప్పు,
ఏం చెప్పాలి సార్?
ఏం చెప్పాలా?
క్వశ్చన్ అడగండి సార్, ఏం చెప్పమంటారు?
నీ ఒపీనియన్ చెప్పబ్బా.
Sir, critical care learning 50 to 60% is from the practice the seniors do. Okay, whatever the consultant, the student is under. So all chese practice one probably 50 to 60% of the learning వస్తుంది. Until unless you do a logical and ethical practice, you can't teach your students the same.
లాజికల్
You
అండ్
can't.
ఎథికల్. ఓకే.
Yes. అంటే LFT derange అని ప్రతి పేషెంట్ కి అర్సగాల్ పెట్టి, అండ్ ఇన్ ద క్లాస్ యూ కాంట్ సే దట్ అర్సగాల్ ఈస్ నాట్ యూజ్డ్ ఇన్ derange LFT. So it should be. Until unless you do that practically, your students don't learn it. You say it 100 times, you say it 1000 times, you see, give an example, still మీరు ప్రాక్టీస్ చేసిందే గుర్తుంటుంది. So 50% to 60% is learning from my side is from the practice. And until unless the quality of the critical care or the practice of the critical care does not increase, how much we teach, they remember only the practice they do.
So one, as Jekina said, duration. Second, you said
Yes, that is completely true, sir. And critical care is not a process of 1 year or 2 years. It is a life. I think it is a lifelong process, and it is so vast, and it can't be completed in 1 or 2 years or 3 years.
so it is like, for example, learning for 1 year is to knowing the depth of it. After that, it's a practicing and learning.
Yes.
Yeah. And continuously, I said, the hero of the simulation is the debriefing. So every time, whatever we do, we have to again assess ourselves and reassess and introspect and keep improving and increasing our potential and knowledge and as well as skills.
Sir, learning is lifelong. That doesn't
Yeah.
mean the course should be 1 year or 2 years. Because a 1 year అయిపోయిన తర్వాత they will be extremely busy that there will be much learning. Because there is only a practice. So learning should be standardized and and basics should be very strong also. Basics is strong only because if you want to talk with a physician or a pulmonologist, basics has to be strong. Otherwise, మనం ఏంటంటే as we tell only about pulse pressure variation, systolic pressure variation. So what language we are talking with the physician, or they don't understand. What they are talking, we don't understand. So there is a mistrust by the physician or a pulmonologist on us. Because if you know their language, then they will automatically support us that we know about them. Because when we don't know the basic things, then it is a problem.
That is the first thing which I am not liking at all when people are talking. When you say that critical care is a separate specialty, why do you talk about a physician and pulmonologist? It is a separate specialty, whoever it may be. So that is the reason I am telling that, because we are all anesthetic, we should not talk like that, because our perception should increase our knowledge and the skill in the medicine and the from pulmonology. So what is the perspective of, I'll just talk Ram Naidu.
Hello, sir. వినబడుతుందా?
సార్ ఏదో డిస్కనెక్ట్ అయినట్టుంది సార్.
Yeah.
Hello?
Especially anyone entering into the some super specialty from different backgrounds. Generally, along with us, we will carry a thought that wherever we train, we have our previous knowledge of the base specialty will be there. We are not able to forget that the previous impacts of the specialty. We should first of all come out of that. We have to learn, first of all, we should forget what we learned, and we have to see as the evolving specialty from the basic. And we have to improve our skills, and we have to continue to see as the continuing growing knowledge, and we have to see different ways to simplify the work and for the growth of the branch.
Sir, I will tell my opinion. The final word is target. ఉంది సరే మేడం ఫైనల్ మాత్రం నేను చెప్తాను చెప్పండి మేడం 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 చెప్పండి మైక్ తీసుకోండి చెప్పండి మీ ఒపీనియన్
Hi, good morning. Regarding entrance list, like, as everybody said, and particularly when you're from one branch, don't think like this or pulmonologist or division, there are the a good entrance list, but all of us like for a positive thing about the anesthesiologist, we learn lot of physiology, so that's very important for an intensivist to have good physiology knowledge to play around with critically ill patients. But once you enter the critical care, like diploma or fellowship, you have to learn a lot more than just anesthesia part. So as Dr. Saumedhan said, it's not just one department. When you go into critical care, you have to learn about a lot of medical conditions, lot of medicine things, not just learning, knowing the lines and things, not just technical things. You have to improve your knowledge, you have to widen your horizon, then only you can become good intensivist. And regarding teaching and learning, like a teacher should have good rapport with the team, with the students, with the multidisciplinary team in the hospital, and involve other people also to teach the students. Whoever is good in what subject, you have to encourage and include them to teach. And I feel like not just teaching in a classroom, it's more of involving them in the treatment of patient, bedside teaching and scenarios, and what all Varalakshmi said so far, like you have to do all that in modern teaching, not just sitting in the class and teaching. It doesn't work for critical care students. So, and regarding learners also, they have to show interest, enthusiasm, get involved. Don't hesitate to answer and they come out with whatever they know and try to improve, and that's how it should be, not just one side talking like that. So maybe a group discussion, or take small topics and discuss about it and divide between the students, like some parts of a topic to each one and then come up with the own thing in a class discussion like that. So those kind of things will improve learning and, yeah. So that's how I feel. Okay, thank you.
Thank you.
Sir, Mike, Mike. Sir, there is a matter. English.
మేడం మీ థాట్ నిజంగా చాలా బాగుంది, చాలా ఇంట్రెస్టింగ్. నాకు యాక్చువల్లీ మీద వెరీ ఇప్పుడు నాకు కల కానీ మేబీ 3000 ఫర్ అనుకుంటున్నాను. ఓన్లీ అట్లీస్ట్ ఐ విల్
And to teach, because I'm not able to teach, I'm teaching how to teach.
అంటే నేనైతే క్రిటికల్ కేర్ ఫస్ట్ నేను ఎందుకు వచ్చానంటే చాలా మంది పేషెంట్ సిక్ అవగానే నేను వాట్ ఐ సీ ఇండియన్స్ సిక్ అవగానే పోతాడు వదిలేస్తారు. ఓపీడీ ప్రాక్టీస్ ఐసీయూ ప్రాక్టీస్ డెఫినెట్లీ డిఫరెంట్. ఇప్పుడున్న ప్రాబ్లం ఏంటంటే వెనకంతా కష్టపడేది మనము. మనకి ఓపీడీ ఎవరు బాగా చేస్తారు ఆడే హీరో, కానీ వెనకంతా వచ్చేసే వాళ్ళు హీరో కనబడుతుంది. సరే సౌండ్ వస్తుంది.
అది ఆపితే సరిపోతుంది. అదేం కాదు, మైక్ ఆపితే సరిపోతుంది, ఏం కాదు.
సో నాకే నేను అర్థం ఏంటో నేను చదువుతామని నాకు నేను అంత ప్రైజ్ స్టూడెంట్ కాబట్టి చదువుతామని కొద్దిగా కుతూహలంతో వెళ్ళి చదవచ్చు. కానీ ఇక్కడికి వచ్చాక ఇంకా సినారీ ఇంకా మనం ఇంకా డ్యూటీ దాటులని చూస్తారని నాకు కొద్దిగా బాగా అనిపించింది. దాన్ని ఇంప్రూవ్ చేయడానికి ఫస్ట్ ఏంటంటే నేను చాలా మంది అందరితో మాట్లాడాక నాకు అర్థం ఏంటంటే ఫస్ట్ మనం నాలెడ్జ్ అనేది ఉండాలి. నాలెడ్జ్ ఉండాలి, కమ్యూనికేషన్ స్కిల్స్ ఉండాలి, కోఆర్డినేట్ చేయాలి.
ఆల్రెడీ మైండ్ లాంటిది.
అంతే సార్,
బాగా వస్తాయి
అలాగే సార్.
అలాగే.
అలాగే సో నాలెడ్జ్, కమ్యూనికేషన్, కోఆర్డినేషన్, పేషెంట్ అవుట్కమ్. కానీ అంటే నేను ఇంకా అబ్జర్వేషన్ అంటే ఎంత మన ఐక్యూతో డయాగ్నోసిస్ చేసినా గ్రౌండ్ లెవెల్ లో కేర్ అవుతుందో లేదో చూసుకోవడం కూడా ఇంపార్టెంట్. నేను ఎక్కడికి వచ్చాక చాలా నేర్చుకున్నాను. అది వెళ్ళిందంటే ఆటోమేటిక్ గా పేషెంట్ రికవర్ అవుతారు. సో నేను ఇక్కడికి వచ్చాకనంటే ఒక్కడం చేయడం ఇంపాసిబుల్. మనతో పాటు 10 మందికి నేర్పాలి, నేర్పించుకోవాలి, 10 మందితో పాటు నడాలి. అప్పుడే మన డిపార్ట్మెంట్ డెవలప్ అవుతుందని నాకు అర్థమైంది. నెక్స్ట్ 5 years లో నా గోల్ ఏంటంటే మన క్రిటికల్ కేర్ డిపార్ట్మెంట్ ఎస్టాబ్లిష్ అవ్వాలి, మనకంటూ ఒక గుర్తింపు ఉండాలి. అంత యూనో అంటే మన సైడ్ అన్ని మన సైడే ఉండాలి. అందరూ వచ్చి దాంట్లో వచ్చి మాట్లాడాలి. ఇది నా నెక్స్ట్ 5 years నా గోల్. దానికోసం అందరూ సపోర్ట్ చేస్తే డెఫినెట్ గా ఓకే.
మాట్లాడాలి, వేరే మీ గురించి మాట్లాడాలి, వేరే గురించి మాట్లాడకూడదు. నెక్స్ట్ 5 years
నా గురించి కాదు సార్, అంటే క్రిటికల్ కేర్
క్రిటికల్ కేర్ గురించి.
క్రిటికల్ కేర్ గురించే మనం డెవలప్ చేయడానికి ట్రై చేయాలి సార్.
కరెక్టే.
మన
ఇప్పుడు the question is teaching learning.
Exactly.
Then nothing else.
Exactly.
See our idea. See today our question is our idea is what is the teaching and learning of critical, nothing else.
ఇప్పుడు టీచ్
So,
చేస్తేనే
అర్థమైంది.
లర్న్ చేస్తేనే మనతో పాటు పని
కాదు, అది యూనివర్సల్ ఫ్యాక్టర్.
Universal factor. Ganesh,
ప్రాక్టికల్ గా on a
Ganesh,
daily basis, how
please.
to teach, how to learn, how to make somebody learn.
అక్కడే మాట్లాడుతున్నాం
కదా.
ఇంకా
స్టూడెంట్స్ డైలీ ఏదో టాపిక్ నేర్చుకున్నాము అని సాటిస్ఫై అయ్యారు. కేసు చూస్తే కొత్త కేసులో మన ఆఫీస్లో వస్తుంటే మంచిది. స్టూడెంట్స్ ప్రొజెక్ట్ ఉండదు. ఇప్పుడు మనం కన్సల్టెంట్స్ తక్కువ కాబట్టి ఆటోమేటిక్ గా రెసిడెంట్స్ లుకింగ్ అవుట్ ఐసీయూ. సో మీరు సరిగ్గా నేర్చుకోకపోతే స్టూడెంట్స్ సిక్ అయ్యారు అనుకోండి, నాకు ఎవరు టీచర్ గా ఉంటారు. సో మీరు ఈ 1 year లోనే అట్లీస్ట్ ఇంపార్టెంట్ కేసెస్ కన్సల్టెంట్స్ ని అలా పొద్దునే ఈవినింగ్ ఆఫ్టర్ 2 hours నుంచి ఫ్రీ అవుతారు కాబట్టి ఎగ్జాక్ట్ మేము 8 o'clock వచ్చి 5 o'clock వెళ్ళిపోతాం అనే మైండ్ సెట్ తీసి వస్తే అండ్ ఈ 1 year అంటే కష్టపడితే ఫ్యూచర్ అంటే బాగుంటుంది. కాకపోతే తర్వాత కూడా కష్టపడాల్సి వస్తుంది. అది నాకు మా పవన్ సార్ ఇప్పుడు నేను 2 years లో కష్టపడ్డాను కాబట్టి ఇప్పుడు ఒకసారి కొంచెం బుక్ చేయలేదు. మీరు ఎప్పుడు నా డౌట్స్ అడగడం ఏంటి అని. సో నేను ఒకసారి డౌట్ అడగడం మొదలు పెడితే ఎవరైనా ఆపరేటర్ అంటారు. సో ఈ 1 year బాగా కష్టపడితే ఫ్యూచర్ అంతా ఈజీ అవుతుంది. మీ 1 year కొంచెం టైంకి వెళ్ళిపోవాలి. అంటే క్రిటికల్ కేర్ అనేది మోస్ట్లీ మనం నేర్చుకునేది నైట్ టైం, ఎందుకంటే మార్నింగ్ కన్సల్టెంట్స్ ఉంటారు అండ్ ఫిజిషియన్స్ ఉంటారు కాబట్టి అట్లీస్ట్ మనకి బ్యాకప్ ఉంటుంది. సో ఎప్పుడైనా మనం ఒక సినారియో చూసినప్పుడు మన వే ఆఫ్ థింకింగ్ నైట్ టైం వస్తుంది అన్నమాట. ఇప్పుడు సడన్గా హైపర్ టెన్షన్ వచ్చింది, ఎందుకు హైపర్ టెన్షన్ వచ్చింది, కార్డియాక్ లేకపోతే పల్మనరీ కాల్స్ లేకపోతే సిస్టిస్ అని ఐడియా రావాలంటే జస్ట్ నైట్ టైం మన ఎవరు ఉండరు కాబట్టి జస్ట్ నేను ఏదో చేసి నేను బతికించాలని ఆలోచన వస్తుంది. ఆటోమేటిక్ అప్పుడే నేర్చుకుంటాం. ఇప్పుడు కొంచెం ఎక్కువ మంది ఆ, ఎక్కువ మంది రిలాక్స్ అంటే నేను యాక్చువల్ గా హైదరాబాద్ ఉన్నప్పుడు 3 years కష్టపడితే ఫ్యూచర్ బాగుంటుంది, స్టైఫండ్ నాకు సంబంధం లేదు అని టార్చర్ పెట్టడం పర్లేదు అని చెప్పి యాక్చువల్ గా నేను కేర్ పర్లేదు. సో నాకు ఇది అంటే ఈజీగా జస్ట్ మామూలుగా మార్నింగ్ 8 to 1 కి పని, ఈవినింగ్ 1 to 5 ఖాళీ ఉండే గురించి చాలా వచ్చినా సరే నేను జాయిన్ అవ్వలేదు. అంటే అకాడమిక్స్ ఒకటే కాదు, అకాడమిక్స్ తో పాటు పేషెంట్ రోడ్ ఉండాలి అన్నమాట. నెక్స్ట్ ఐడిసిసి స్టూడెంట్స్ మంది ఇప్పుడు జాయిన్ అయ్యారు. సో నా విషయం ఏంటంటే మంచిగా నేర్చుకుని రండి. అంటే అకాడమిక్స్ ప్రోటోకాల్స్, హాస్పిటల్ ఐసీయూలోని ప్రోటోకాల్స్ ఉండాలి. ఇప్పుడు మన వైజాగ్ డ్రాబ్యాక్ మెయిన్ ఏంటంటే తక్కువ మంది ఫ్యాకల్టీ కాబట్టి మీకు ఎక్కువ టీచ్ చేయలేకపోతున్నాం. సో మీరు నేర్చుకోవాలంటే 1 hour ఎక్స్ట్రా ఉండి నేర్చుకోవాలి. సో స్కూల్ ఫీడింగ్ ఏమి ఉండదు. జస్ట్ మీరు సార్ నేను ఇప్పుడు ఏదో పారాపేట్ పర్సన్ ఉంది, పారాపేట్ పర్సన్ మీరు చదివిన తర్వాత నాకు అడిగితే నేను అప్రోచ్ చెప్తాను. అంతేగాని డైరెక్ట్ వచ్చినా నేను ఎక్స్ప్లెయిన్ చేయాలంటే సో మీరు ఒక అట్లీస్ట్ ఒక బుక్ లో ఒక రీడింగ్ ఇస్తే తర్వాత అర్థం మేము చెప్తాం. మీ సైడ్ నుంచి ఏమి లేకుండా ఇప్పుడు మనం అప్పుడు చెప్పాలంటే మాకు ఫ్యామిలీ ఉంటుంది, కమిట్మెంట్స్ ఉంటాయి కాబట్టి సో మీరు ఒక 1 hour కొంచెం స్ట్రెచ్ అవుతే 1 hour స్టూడెంట్స్ స్టడీ పీరియడ్ లో లైఫ్ అనేది కొంచెం బాగుంటుంది. ఇబ్బంది పట్టు ఇప్పుడు మేము సిక్ అయినా సరే మా ఫ్యూచర్లో మేము ఫైట్ చేస్తాం.
సతీష్ మీరు మాట్లాడండి.
Sir, morning, sir. Morning, the team. Got a few issues. So one thing is, as a teacher, I don't have much experience. Only 2 years of teacher. Hello.
చెప్పండి.
Am I audible properly?
ఎస్ ఎస్
Okay. Hello.
యు ఆర్ ఆడిబుల్.
Sir. So as a teacher, my experience is very less. But as a student, still I am a student. I always want to learn whatever the opportunity I get. People most of the times ఏమవుతుందంటే 2 years ఏదో చేసేస్తే అయిపోయింది, ఇంకా నేను ఇంటెన్షనిస్ట్ అయిపోయాను, ఐ కెన్ టేక్ కేర్ ఆఫ్ ఎన్ ఐసీయూ, ఐ కెన్ ఎర్న్ మనీ అనే టైప్లోని ఒకటి కాన్సెప్ట్. దట్ ఈస్ రాంగ్, ఫస్ట్ థింగ్. సెకండ్ థింగ్ ఈస్ లెవెల్ ఆఫ్ ఐసీయూస్. సి ఒక స్మాల్ నర్సింగ్ హోమ్ లో ఒక వెంటిలేటర్ పెట్టి పేషెంట్ వెంటిలేటర్ ఎక్కించేది కూడా ఐసీయూఏ. టెరిషరీ కేర్ ఐసీయూ లైక్ క్లీవ్లాండ్ క్లినిక్ లో మనం చూసింది కూడా ఐసీయూఏ. సో ద లెవెల్ ఆఫ్ కేర్ గివెన్ ఈజ్ ప్రపోర్షనేట్ టు ది లెవెల్ ఆఫ్ సపోర్ట్ వీఆర్ గోయింగ్ టు గెట్ ఫ్రమ్ ద మేనేజ్మెంట్. అండ్ మేజర్ హర్డిల్ ఈస్ ఫైనాన్సెస్. We know many things, but we cannot implement because of the constraints like finances and acceptance by the primary, because they are ignorant. They don't know the beauty of the life extending measures like ECMO. చాలా మంది కన్సల్టెంట్స్ ECMO అంటే కాస్ట్ అండి వద్దు, లేకపోతే చాలా మంది ఆ ECMO పెట్టిన వాళ్ళు ఎవరు బతకలేదు, ఇలాంటి కాన్సెప్ట్స్ తోటి ఉన్న వాళ్ళందరినీ ఎడ్యుకేట్ చేయడం. సో వాట్ ఐ బిలీవ్ ఇస్ we have to understand that first of all we should have a independent branch like admission criteria. If we can admit patient under our care, we can give better care. That is, but hospital will not accept that. This financial constraint, and we are not as per se crowd pullers. No patient will come back to us and admit under us because our admission numbers are very less. Second thing is we have limitations, financial limitations. As long as these two are there, I don't think critical care will flourish in this country independently. That's my opinion.
Thank you, Satish. I just want last. Thank you, Satish.
I just
Thank you.
want last 3 people, Akshit and Mohan Rao and David to close. Akshit? Because the reason why I am asking him is, he's a post MBBS guy and who's into the critical care and doing, and now actually well settled in Gujarat. So now he is there in that. I just want his opinion about it, because he should keep on changing his perception, because always being a student and learner is very important. But I want his opinion.
Good morning, Manada. Thanks for the question of sir. It was like initially I joined.
No, not for you. Actually, we just want to know what is the critical teaching and learning. What do you want to speak about?
Coming to critical care, I feel more of a teaching should be done on the bedside, because whatever we learn and what all pitfalls we see, this critical care is branch where we can, it is like you need to identify complications at the bedside and then know how to manage it. it is like a routine traditional teaching, like what is the case, all that can be learned in book even and at the free time. But how complication has to be identified, because not everything is clearly visible. So you need to identify how to learn a complication, how to deal with it, and how to just get over the complication. That is more important. Bedside teaching is more important.
Yeah, Mahesh, tell your words, what is your difference you are seeing in Manipal Hospital and how do you think it's important or?
So morning, myself, Dr. Kishore, doing dialysis work in medical management.
What is the replicate teaching and learning you want to? But you want to say? Fast.
In my perception, as Ganesh said, that students are more proactive. That's what I think. We should be proactive, interacting with their consultants. You have to spend more time, not like time bound. You have to spend more time with consultant as well as patients. And you have to be interactive. So, and basically, discussion academics time on the technical care field. So, this started, sir. Who are available, we have to discuss with them, sir. Discuss time. So, possible present at that scenario of this discussion, I have to move on, sir. That's what I got. So, let's say we are waiting for other people and then just already postponing schedule. So,
Good point.
later on, at least we have some Zoom and other things on that, so they will join in that.
Becomes easy. Keep ready. Ramya is keeping his lectures ready every time. Whenever the time comes, they call the students and sit and talk. Mondo does the same thing every day, evening. Basically, I don't say, okay, ready to show.
That's why I tell my students, don't say what time I'm going home and Chudaptu, what have I learned today and in Chudam.
Thanks. Sir,
Today's topic is teaching and learning. So my journey is the last 1 year. In CMC, I'm very happy in CMC. The thing is, the teachers came on, they tried in different form of the work. One is from USA, one is from UK, one is from Australia. Australia also, 4 different areas. So they have in Australia also, if you look into that, they have 4 different protocols and things. And I have to finish my idea. The exam, I went and asked the madam. And most of the questions are medicine. Why you are thinking about your anesthesia? You are a critical care physician. You are doing critical care medicine. Whatever it may be, if you understand the critical care, they have to acquire the knowledge of medicine. And other thing is that J.V. Peterson used to be from 11 to 1 o'clock. That's a loss. Other things. But somehow this is not happening. After that, I learned a lot from the teacher also, and from the indirectly from the governments, because he has given so many opportunities. Whenever he's giving opportunities, I go and read. Means so I have to read before going for giving the call. Actually, also Swati actually asked me, sir, Ramnadev sir, to ask about the PM. I know about PM. But I read a lot, means long back. I thought, okay, read and come on. I will teach today because I also teach. So as a teacher, we are also continuously. And interesting, I thought I'm very good about PRVC. Yesterday I read another article. I learned 2 words. I made a PPT also to teach our students. So the teaching is a very, very actually very good thing. So for students, I am asking one basic question. Daily, you are ventilating with a volume control. Why? One advantage of volume control, the Mahesh, students. Just one advantage is simple. Okay. Another thing, what is the difference between volume control and pressure control? People generally will tell that Sinju, it is volume
Guaranteed.
value guaranteed. It is true. Always volume guaranteed if you are given a statement that it is 100% volume guaranteed.
No.
No. When you go as a teacher in depth, as a student also in depth, it is not a volume, always not guaranteed. That is also, as a teacher also, you should know in which conditions it is not volume guaranteed. So many things are there and teaching and that.
As a NABH assistant, so are you going to focus more into the critical care in future?
Yes, sir. Yes, sir.
Because that's very important, because you go to the hospitals for NABH assessment, and throughout your life, you are going to do more than 100 to 200 hospitals you are going to do. Are you going to inculcate this teaching and learning and importance of critical care?
One more thing is, my madam also told this 2 years or 3 years period is just your smelling critical care.
Smelling.
Smell, just to, if you become a smell, you have to become a consultant, to see everything. You will need another 5 to 6 years training under one senior. Maybe I did. And another thing is what we are facing, our juniors also facing challenges in critical care.
Training and qualified experienced expert critical care is important.
No.
Not just senior like me.
Sorry.
So many things.
Another things, these are big challenge in as a intensive learning and practices. When you think that you are a driver for your car, but when you enter the intensive care, so many drivers are doing. That is why our one. So actually we wanted to put our knowledge and the knowledge after when the patient is iterating, go to the literature, to the things. So if you are a single driver, most of the maybe you see in US also most of the ICUs well sophisticated mortality is there. That is it. But one more is that person. Some people think that so many you do like this, things as well. So if you go on talking my experience about this, I think thank you, Varalakshmi.
Thank you all. We close the session after a few words. Teaching and learning. I'm an anesthesiologist after finishing work so many years in critical care. Practiced anesthesiology in cardiac and general, maybe a few years, 6 to 7 years. After that, because I like critical care, so practicing critical care, I thought I am an intensivist before getting IDCCM and before getting this training. When Mohan sir first initially went to Chennai and he became intensivist and he learned critical care, and he asked me then, Masu, I am already intensivist. What more I will get? I know ventilation, mechanical ventilation. I know how to treat a patient on bed. I'm doing that job already. What more I learn? What is there? Alaanti thought process తో ఉన్నాను. After going there also, I felt same thing they are doing. What we are doing, they are doing. ఎందుకు నేను అనవసరం వచ్చాను, నేనేం నేర్చుకుంటాను ఇక్కడ. That was my thought. After time is going on, few months, 2, 3 months, 4 months, 6 months, then I was going into depth. Because the teachers there, as Mohan Rao said, they are from different countries, trained in different countries, some US, UK and Australia, various
parts of the world they are giving the knowledge to us and they are going into depth. So then I started going depth. Before superficial, వచ్చాడు పేషెంట్ ట్యూబ్ వేసాం వెంటిలేటర్ పెట్టాం ఏవో మోడ్స్ పెట్టాం అయిపోయింది వస్తే వచ్చాడు పోతే పోయాడు. No, then started going into depth. Each patient. Keep on going depth, not stopping one day. Keep on daily, continuously going into depth. Then started thinking, that is called critical analysis, critical thinking, and the continuous evaluation. అసలు ఏంటి జరుగుతుంది కంటిన్యూస్ ఆ కేసు నుంచి ఆలోచించడం దాని గురించే మళ్ళా ఏదన్నా రివ్యూ చేయడం ఏదన్నా బుక్స్ చూసి లేదంటే ఇంటర్నెట్ లోకి వెళ్ళి దాని గురించి స్టడీ చేయడం అలాగా డెప్త్ లోకి వెళ్తుంటే దెన్ ఐ స్టార్టెడ్ ఫైండింగ్ ద ఫ్రూట్స్ ఆఫ్ ద క్రిటికల్ థింకింగ్ అంటే రిజల్ట్స్ ఇంత డెప్త్ లోకి వెళ్తే దెన్ స్టార్టెడ్ సీయింగ్ ద రిజల్ట్స్. దెన్ ఐ సా ద డిఫరెన్స్ బిట్వీన్ what I was doing and what I am doing, and I am learning, actually learning and doing from the seniors and the teachers, everybody. So don't stop there. Diagnosis అయిపోయింది ఇది pneumonia next round and no, you need to continue the process. Don't stop there. The pneumonia patient might have some autoimmune disease background. So we stop there. You are losing so many things. Go in depth. Keep on going in depth. Depends on the patient, what the symptoms and signs and other investigations is giving to us. Keep on going into depth. Keep on reading. Keep on reading about that, everything about this critical care and learning and discussing with the seniors. Everybody. You don't the what is your thinking? So many times I call Mohan sir, Mohan, even Chennai Gani, Hyderabad, phone చేసి ఏమైంది సార్ ఇది ఇంకా ఏమైనా చేయొచ్చు ఇంకా డెప్త్గా వెళ్ళగలాలి ఇంకా ఏమైనా చేయాలి. So that discussion among our people and our teachers also is important. Keep on reading into the case, daily case basis. ఈ కేసు గురించి మొత్తం డీటెయిల్ గా ఇంకా డెప్త్ లోకి వెళ్తాం. Somebody coming from this some area, sir, ఈ పేషెంట్ ఇక్కడ రికవర్ అవ్వట్లేదు, I want to come to your ICU. We have a conference అంటే మనం అంటే how much responsibility you have. So you will be a continuous student and a teacher and a learner. So I am advising the students mainly, don't read for only examination. Read for the patient and read for you improve your knowledge and keep on going into the depth. Critical analysis and critical thinking and continuous evaluation is the key of critical care. What I felt. A best example, the best student transformed to the best teacher is Varalakshmi, because she was our student. Seeing from the answer, DNB student గా అక్కడ నుంచి how she developed slowly into critical care and she joined in DM and she started teaching and how to become a good teacher, very efficient teacher. So, okay, student, okay, good teacher laga ela avvalo, she is the benchmark. I felt that. And a good leader and good teacher is Mohan Maharashtra. I learned so many things. Elagante, he will give lot of opportunities. You do it, I will face it. The result, consequences I will face. You do it, you learn it. I will face that consequence, bad consequence. Good consequence, you face it. అంటే దత్త అయితే నేను చూసుకుంటాను, ఇంప్రూవ్ అయితే నువ్వు తీసుకో. So that type of teacher is very important to allow you to do everything on bedside. Chances, that is also is very important. But also being a teacher, you have to give the opportunities and the time to your student. Otherwise వాడు తిట్టుకుంటాడు, నాకేం నేర్పట్లేదు కదా, నాకేం చెప్పట్లేదు అని ఆయన చేసుకుంటాడు అలాంటివి. So teachers is very important, for students also is very important. Critical analysis, critical thinking and continuous evaluation. Continuous, not because we were so many things we can pick up. Thank you sir, for providing medical hospital for good బ్రేక్ఫాస్ట్, ఎక్సలెంట్ బ్రేక్ఫాస్ట్ సార్. బాగుంటుంది సార్. స్పెషల్ బ్రేక్ఫాస్ట్ కంటే ఇదే బాగుంది. థ్యాంక్ యూ ఆల్. Thank you very much for all of you coming with a lot of efforts and coming here. And Varalakshmi, ఒకసారి ఒక conclusion points, 10 points అందరూ మాట్లాడి దాన్ని బట్టి ఒకసారి అందరికి పెట్టమ్మా. Thank you very much all of you.
What a good teacher should be, what a good learner should be, but I didn't.
Thank you. వెయిట్ చేసి అందరూ వస్తే సార్ అంతే సార్.